Thank you very much for accompanying me to run this lecture because I have a pickup that's going. So this is the lymph flow procedure for desert foot, and this is our experience of it. These are my disclosures. Critical limb ischemia is associated with high cost to society. It's a global epidemic. You see it in the lab every day. Many of our patients are ineligible for further revascularization for conventional techniques, and we estimate, and some of the literature has been out there, and we estimate the number to be approximately 20%. And this is what Roberto calls a small artery disease. Now, we know this and we see this every day. Amputation is more than just losing a leg. So the concept of venous arterialization is come from an artery. The artery is no longer reconstructible. You would come through the vein and then pass the valves and hit the capillary bed. It's like stuck in a New York traffic jam. You have to try and get on the other side of the road and get an alternate path for perfusion. So for those who are not familiar with the device, you will come with an antegrade 7 French sheath, a retrograde 5 French sheath in the vein, and use a device that will align both the artery and venous catheters, punch a needle across, put a wire, pre-dilate, and then stack it up with stents. But before that, you use a 4 French valvulotome to lyse the valves and allow the blood, arterialized blood, to hit to the distal extremity of the foot. And the aim is to have pressurized blood going into the foot. To perfuse the capillary bed. So this is a proprietary tapered stent. So within the context of a clinical trial, the first in man was done in Singapore, and there's a CE mark registry going on. Promise One is a US visibility trial that was done by Jihad and a few others, and he recently presented the data. And in our first in man 7 no option patients, all of them were diabetic, and we had a good technical success with a good median time to wound healing as well as limb salvage, and assessment of perfusion by TCPO2 was a very, very significant rise from a pre-procedural TCPO2 of 8 and culminating with a TCPO2 of 59 at the time of wound healing. There's a typical TCPO2 that will rise after 2 months, breaching that 40 millimeters mercury that one would say is the cutoff for wound healing. This is the Promise One US study for the EFS. So in this study of about 10 patients, 100% AFS technical success rate was high. Patency rate at 1 month was high, but dropped at 6 months. Several of these patients underwent re-intervention, and wound healing is still pretty good. At 50% of these wounds, patients had 80 to 90% wound healing by 6 months. One of our patients that we had done in Holland actually was able to celebrate his honeymoon and bring his wife over here to the Big Apple here, and was able to work as a mover. So one of the more personal stories. One of our patients, 82-year-old, severe rest pain, non-healing wound for 6 months, diabetic, small vessel disease, angioplasty could only bring the blood down to here, and this patient was arterialized. And for non-healing wound for 6 months with a desert-looking foot, we were able to get this in full wound healing in about 3 months. Another patient had difficulty in trying to get an antegrade approach to the lateral plantar artery and a retrograde. We all did an open cut down on the dorsalis pedis to try and get that running. This failed, and as a result of that, the cut down was ischemic after that. Infrared thermography was cold, and with low TCPO2, we arterialized the veins and had the TCPO2 rise up to 55, had to do a transmetatarsal amputation, and in 6 months this wound had actually healed. What was more interesting was that subsequent to that, the graft occluded, but because the wound had healed, we did no re-intervention. And despite the graft occlusion, the TCPO2 remained high. If you look at the original TCPO2 of 16 and 25, this patient remains symptom-free and re-intervention-free, and with the TCPO2 that's high, almost 2 years after the procedure, a phenomenon that we see in several of our patients that we can't quite understand. Another patient like that, this patient had repeat thrombotic episodes with protein C and protein S deficiency, multiple interventions and thrombolysis of the arch, not a desert foot, but a desert leg, severe rest pain, TCPO2 of 4 and 23. This patient was treated with venous arterialization, high TCPO2, transmetatarsal amputation, wound had healed. Again, the graft had occluded, and he remains symptom-free with a high TCPO2, which is quite perplexing for us. One of the cases, I think is similar to a case that Dr. Luxstein had presented with very small vessels. You're unable to open the posterior. You don't want to jeopardize the toes by doing a transplantar intervention. We selectively did a perfusion of the veins of the posterior circulation, and with that, at 4 months, we were able to heal gangrene with a rise in TCPO2. Again, this occluded after some months, and this TCPO2 still remains very high as compared to the original TCPO2 before any venous arterialization had been done, and another similar case like that. I'll just try to move along a little bit. So in summary, small artery disease is currently untreatable. Desert foots are increasing common occurrence. Percutaneous DVA may hold the key to revascularization. Continued and improved perfusion after DVA graft occludes is seen in some patients, and it warrants investigation, and worldwide experience across experience centers is encouraging. We hope to publish a 4-center experience from Europe and Singapore in the next couple of months. Thank you very much.